Everything was okay, came in spontaneous labor at 37 plus. She appeared to be progressing very well, and she ruptured her membrane spontaneously in the morning at 6. There appeared to be a little bit more liquor than was usual. She was 7 centimeters at that time, an engaged head at 0, so we'd usually say, oh, this one is going to deliver. 5 minutes down the line, someone calls for help. She appears unconscious, she's pulseless, BP is not recordable, and she is not breathing.
Sister, call one will you? Doctor, just both
Code 1 maternal collapse labor room. Code 1 maternal collapse labor room. Code 1 maternal collapse labor room.
Now, take over. 1, 2, 3, 4, 5, 6. That is what happened.
Sir, actually the patient has collapsed. We have done an AR of 1 hour before, and 1 hour later she complained of some severe chest discomfort. Immediately she collapsed.
Current pulse is
happened with the pulse.
like arrest?
Yes,
Maybe an emergency situation?
Yes.
Okay, Jacob?
Yes.
Okay, please take over.
Yes. ORT team Nibu, continue CPR, maintain high quality CPR. Julius, take the airway and breathing, ensure good back mask ventilation. Kashi, please switch on the monitor, we'll see the rhythm. Marina, ensure that you have a good IV cannula which is functioning.
Jaji, why don't you displace the uterus? പെട്ടെന്ന് കണ്ടുവല്ലോ ചെസ്റ്റ് ഡിസ്കംഫർട്ട് പറഞ്ഞു. സംശയിക്കുന്ന എന്താണെന്ന് വെച്ചാൽ ബേബിയുടെ ചുറ്റുമുള്ള ഫ്ലൂയിഡ് മദറിൻ്റെ സർക്കുലേഷനിൽ കയറിയത് പോയാൽ തോന്നുന്നത്. അതൊരു ഇത്തിരി സീരിയസ് സിറ്റുവേഷനാണ്. നമ്മളതിന് മദറിൻ്റെ ഹാർട്ടിൻ്റെ ഇതൊക്കെ നോക്കാനുണ്ട്. അത് നമ്മൾ ചെയ്യാൻ പോവുകയാണ് കേട്ടോ. ഇവിടെ സൗകര്യമായിട്ടിരിക്കും. ഞങ്ങൾ എല്ലാം ചെയ്യാം. നമ്മൾ പറ്റുന്നതെല്ലാം ചെയ്യാൻ പോവുക കേട്ടോ. സമാധാനമായിട്ടിരിക്കുക കേട്ടോ. സമാധാനമായിട്ടിരിക്കുക കേട്ടോ. 25, 26, 27, 28, 29, 30. 1, 2.
Now the monitor is ready. Stop CPR, we'll check the rhythm.
Rhythm is asystole.
Asystole, ORT team, continue CPR.
CPR is started. 3.
Dr. Julius, maintain airway and ventilation. If not possible, intubate the patient.
Planning to intubate.
Sister Marina, load 1 mg epinephrine. Tell me when it is ready.
Yes, sir. Adrenaline is loaded. Ready.
Okay, 1 mg adrenaline, give IV push bolus.
Yes, adrenaline given and flush the line.
Bindu, please do the documentation and tell me every 2 minutes.
Yes, I will do it.
Sir, I am not able to ventilate. Can I go ahead with intubation?
Please go ahead. ORT Nibu, ensure compression is not interrupted.
Okay.
Please give me the tube.
Sir, 2 minutes over.
Okay, stop CPR. Analyze the rhythm.
Analyzing rhythm. Rhythm is still asystole.
She is still in asystole. Continue CPR. Switch roles. Okay, finally we have a problem here. Patient is still in asystole. We have completed 2 cycles, 4 minutes of CPR. Kindly consider expediting the baby delivery.
Let me just check the cervix whether it is fully dilated. No, it is not yet. I think we have to do a section to take the baby out.
Perimotor.
Sister, perimotor section, right?
Yes, ready.
Okay, please open it.
Nice.
No, get me the tray. Open it complete. Take the sheet. Okay. Raji, please get me the knife. Okay. Raji, I'm going to do the section. Vertical incision on the abdomen. Vertical incision on the uterus. All the way down. Tray. Baby's out. Okay. Let me get this green amethyst. Green amethyst. One more. Let me get the suture. Suture. No, not poly. Get me the absorber one. The other one. Needle loader, please. Needle loader. Scissors ready. Thumb forceps. Okay. I'm ready to take full thickness stitch on the uterine wall. Thumb forceps, please. Full thickness stitch on the uterine wall in single layer. Okay, Raji, cut. Cut. Okay, get me the proline. Get me the proline, please. Get me the proline. Yeah, uterus is closed. Just single layer closure of the abdomen.
So, boxing correct ആണോ നോക്കണേ.
Single layer closure of the abdomen. Running stage. Raji, please cut. Abdomen is closed. Just check.
Sir, 2 minutes over.
Okay, stop CPR. Check the rhythm.
Analyzing rhythm. We have an organized rhythm.
Okay, Julius, can you check the pulse?
Pulse present.
Okay, then we have attained ROSC. Well done, team. We will start the post-cardiac arrest care. Dr. Julius, what about the airway and breathing?
The airway is in place. We are getting a saturation of 96%.
Okay, that is good. Marina, what about the circulation? What about the blood pressure?
Blood pressure 90/60, sir.
She is in hypertension. Kindly consider giving some fluids. Dr. Kashi, start some IV fluids.
There seems to be a problem. She's bleeding a little more. Maybe she has gone in for DIC. Why don't we ask the blood bank for some blood products?
Okay, that's a problem, Kashi. Kindly call up the blood bank and ensure that blood products are arranged. What would be the possible diagnosis?
I think thinking about everything, it would have been an amniotic embolism and such a dreaded complication. Thank you very much for getting her back.
Team debriefing. I think as a team, we all did a good job. Now we ship the patient to the ICU for further care. Thank you.
You know that Anu had a very unexpected but serious complication. But thank God, she seems to have come out of it. We still have to give her some blood and blood products. We had to take the baby out by a section. But at the moment, her heartbeat, which was not there before, has come back. We may have to give blood and blood products, and let's hope and pray that she comes round.
What about the baby?
Baby has been given to the newborn baby's doctors. Baby was not crying when it came out, but still heartbeat was there. Let us hope that the baby also will be all right.
So she will be in an ICU?
Yeah,
Anu
she
will be in
has to
ICU.
be, because she has come through a very serious situation. Thank God that she has at least come out of it.
How long she will stay in the hospital?
At least a few days. Depends on how soon the blood problems come back.
Okay.
We had to do a cesarean, and for any future pregnancy she will have to have cesarean. Okay.
So just to run through that video, I think that video was all encompassing. You'll see many of the actors and actresses around, but just so clearly there was a call for help. right? There was a code 1 that was called, announced 3 times, so that's a very important point. There was a team in place. One person assumed the role of the captain and performed very well. We'll go through it later as well, how to check on the pulse and the respiration. Most importantly, you'll notice the patient was wedged first. That is, the uterus was pushed to the left side, so we would get some better circulation. And the rhythm of the resuscitation was perfect. Also, they checked the rhythm of the ECG waves, and asystole is a non-shockable rhythm, as a result of which the defib was not used at all. There was a nurse. This is a trained team, so the nurse was looking at the time because that is very crucial. Most importantly, nobody ran around and looked for artery forceps and blades and this thing. There was post-mortem cesarean section kit that was there. There was a crash cart, and very importantly, the notes about debriefing and the documentation as well. So let me start with Lakshmi Madam. Pailisa in the video had said this is likely to be a case of amniotic fluid embolism. So what would be your take on this? Because very often you see case sheets and death reports where when we don't know what it is, a very loose label of AFE. So what is your take on that?
Yeah, it's in a woman, this is a very typical example, woman in labor. You know that she does not have any underlying disorder, and she knows that she's not in sepsis, and the diagnosis is usually made clinically and is by a process of exclusion. Of course, there are certain criteria, like it usually happens in labor or within 30 minutes of delivery. It's a cardiorespiratory collapse with hypotension and dyspnea, and it is followed by DIC, and there's absence of fever. Of course, histological diagnosis, which is usually by postmortem, is by demonstrating fetal squamous, but it's not mandatory and doesn't always happen. Next slide. Yeah, so it has a very high mortality, maternal and perinatal, and does go through 2 phases. And in the first phase, usually 50% of the mothers die, and of the 50% who survive, they die in the second phase. So you can see that the mortality rates are very high, and resuscitation is exactly as we demonstrated in the video. Start with the checking at the vital signs and support the respiration and the cardiovascular system by vasopressin like norepinephrine, and intubate and ventilate. Correct the DIC when she does go on to the phase of disseminated intravascular coagulation. You need to send the investigations along with the resuscitation. That is after the initial resuscitative measures are done, and that would we have to look at the renal failure, look for blood gases, and look for DIC by using the parameters. A VQ scan or a CTPR only if pulmonary embolism is suspected and if the patient survives the initial resuscitative measures.
We had a very clear detailing from Pailisa as how to go about a perimortem cesarean section. Very few of us in this group would have any experience with the same. And very often the ones who've had, it's usually the mother. We were lucky here, she survived, but that may not always be the case. So, Madam, what are your thoughts on the perimortem cesarean section? What is the message you'd like to get out to the audience?
Even though many of us do not have an opportunity to do this, and I think in their entire lifetime you might do it on a couple of occasions, we need to know, we all must be, as obstetricians, should be very ready. It usually done with the mother is an acute collapse. Amniotic fluid embolism is a classical situation, but it could be collapse due to any condition. And what we need to remember here, the crucial thing is that the fetal neurological damage sets in after about 5 minutes of hypoxia or maternal cardiac arrest, and so you need to start the process at least by 3 or 4 minutes. And so this 4 minutes rule, everybody usually should remember. Within 4 minutes of cardiorespiratory arrest. And so if you're going to do that in such a situation, you can't be waiting for the surgeon. So the person on the spot, generally whoever has some surgical training, usually takes on and does it. And maternal resuscitation, as you saw in this video, should not be stopped while this is being done. That should proceed simultaneously by a different team. If you've got a code blue, or if you've called in enough people, you have a team doing that and you have a team doing this. You certainly need a post-cesarean section kit, because it has got all the essential things and you can't run around at that time. You need not get consent in this kind of situation. Gestational age is assessed only by palpating the uterus. If it is, say, 24, 26 or 28 weeks, 28 would be, we would be more comfortable for fetal salvage. And you need not check fetal heart, waste time doing any of those things, because you know the patient has been in labor and you've done all this earlier. No skin prep, no scarping. Just make a vertical incision, start at the uterine fundus and maybe stop short of the pubic symphysis. And once you've entered the abdomen, you make an again vertical from the fundus to the uterine peritoneal reflection, deliver the baby, single layer closure as we saw it of the uterus, and of course single layer, all layers in one, closure of the abdomen as well. Cord blood should be taken for oxygen saturation and for neonatal resuscitation. And of course, by then you know if the mother is going to respond or not. And if she's showing signs of recovery, she still has a pulse and she has a spontaneous respiration or otherwise, you continue the resuscitative measures and shift her to the ICU. If she, by then she goes into the DIC, which most often will, if it is amniotic fluid embolism, then of course you need to correct that. It could be any other cause of, by now you should have a diagnosis. I think you need to evaluate further and make a diagnosis.
And I guess in the process of resuscitation, whether it is a primary or a multi, usually in the multi, you must palpate the abdomen to rule out a rupture as well, because they can also suddenly collapse.
Yeah.
But Raji, would you like to tell us what really do you put into that if they need to set up a kit like that, which is a very easy thing, which should be there? What are the
Ideally, a
contents?
perimortem cesarean section set should be in the emergency department and in the labor room where you receive the labor patients. And the most important thing in a perimortem set is a surgical knife. It is always better to have a disposable one, because you can save time by assembling the surgical knife. Next thing is a hole towel. The hole should be of a sufficient diameter that you are having only one drape. And Gamgee pads, mops, maybe 3 to 4 in number, cord clamps, needle holder, artery forceps, and scissors to cut.
Perfect. So I think we all need to be organized this way. I know Kannur had done, Dr. Shoni had done the perimortem cesarean and got the mother as well. So Raji, what really, when you say collapse patient, it could be many things. So it's either an and or respiratory and circulatory collapse. And they did show, but how do you really, when you see this in the steps of the drill, how do you really, you pat her on the back? Can you just tell us at first few steps, just the circulation, how you look, the respiration, how you look, is she conscious, is she not conscious?
Whenever you can face a unresponsive patient in labor room at any time, it can be just a syncopal attack in which you get the pulse and the respiration present. Sometimes it may be an intracranial bleed in which the BP will be elevated, pulse and respiration will be present. Or it may be a respiratory arrest in which the cardiac pulsations will be there, but the patient is not breathing. And the third one is the cardiac arrest when the heart is stopped as well as the respiration is also stopped. So to differentiate between this, first of all, the first important step is to check the response of the patient. As you have seen in the video, you have to tap the shoulders of the patient and call her name loudly at least 3 to 4 times. If you are not getting a response, then the next important step is to check the carotid pulse and the respiration immediately. It is not the peripheral pulse, it is the carotid pulse or the central pulse that we are checking. Now, how to check? You have to palpate your thyroid cartilage, slide your 2 fingers laterally to the groove of the sternocleidomastoid muscle. You feel the carotid pulsations there. And how long will you check? It is usually between 5 to 10 seconds. So in order to have uniformity, you are not looking in the watch and counting the time. So to have an uniformity, you can say in your mind 1 in 1000, 2 in 1000, 3 in 1000, 4 in 1000, 5 in 1000. So between 5 to 10 seconds, you have to confirm whether the patient is in cardiac arrest or not. Suppose if the patient is in cardiac arrest, as you have seen in this video, we are calling for the cord for help, cord blue or cord 1 in case of maternal collapse.
And at the same time, remember the patient needs to be wedged. So Reena, we are not going into hemorrhagic collapse because it's been done. And I'm not going to the nuances of the embolic phenomena as well because Dr. Piercy will be taking it tomorrow. But Reena, can you just tell us what really are the causes we should be thinking of when we get a case of collapse?
Yes, madam. Already, collapse due to embolism you have already seen. And the other one commonest cause in our labor room is due to hypovolemic shock or hemorrhagic shock. Usually, hemorrhagic shock, if hemorrhage is seen, it is already described yesterday. Yet I would like to describe one thing, that is concealed hemorrhage. Postnatal patient developing tachycardia, hypotension, and not responding to our treatment, always do a bedside ultrasound to rule out a broad ligament hematoma. Because last year in our district we lost 2 mothers due to broad ligament hematoma. And the other one commonest cause, and always think of rupture uterus in antenatal patient in Pitocin induction. History of abortions may be there. Patient complaints of abdominal pain, blood-stained urine, tachycardia, etc. Always think of rupture uterus. And another one commonest cause in our labor room is vasovagal collapse. As already Raji had said that tachycardia, pulse and respiration will be there, but probably bradycardia. And pelvis is richly supplied with vagal nerve endings, so holding the cervix itself can stimulate a vasovagal attack. And another one is metabolic. A diabetic patient in labor, probably she might have taken her long-acting insulin in the evening. Always think of hypoglycemia if she develop giddiness and cold sweats. And another cause is eclampsia, and we are going to describe it in detail, and embolism already described, and cardiac causes, CVA, patient developing paralysis or stroke. CVA can develop and present it as collapse. And another one is anaphylaxis. We will describe it in detail also.
So we've done something about the amniotic fluid embolism, but now let's take a young primary gravid. She's brought in from the periphery. She's had convulsions at home and she's been brought. She's been on oral labetalol for over a month now, but she hasn't also been in to see her doctor for over a month. She's now 34 weeks. She comes in, she's unresponsive. Her BP is really high, 170, 120. She's a guttural kind of breathing. So Raji, in such a patient, we know that we need to put in, earlier on we used to call it a mouth gag, but now we very clearly say oropharyngeal airway. I'd like you to tell the crowd, what really would you do when you see such a patient?
In this case, actually, the patient is having eclampsia. After that, she comes to the casualty, unresponsive, guttural breathing, high BP. So in guttural breathing, when you say guttural breathing, there is a chance that her mouth is full of secretions, and at any time she can go for a respiratory arrest. So I will deal it as a case of respiratory arrest, rightly. So first of all, I will be checking the response. No response, checking the pulse and breathing absent. Pulse present, you can see the BP is 170, 120. So if there is no breathing, usually we go in a systematic approach in all these cases, that is A, B, C, D. That is airway, breathing, circulation, and D stands for definitive management, drugs, diagnosis, etc. But whenever there is a cardiac arrest, the scenario changes. It is compressions first, C, A, B, D. So here it is only respiratory arrest. So the approach is A, B, C, D. Out of this, A stands for airway, B is the breathing. When you consider these two, airway is actually the passage from the nostrils to the lungs, and B is the process of respiration. So if A or B are affected, the patient can go for a respiratory arrest. So our first point is to correct the airway. In this case, the patient has had eclampsia, so there may be secretions in the mouth, there may be tongue fall. So you have to suck out the secretions first. In order to make the airway patent, the first procedure that you do is a head tilt and a chin lift. Most of the time when you release your hand, again the tongue will be falling back and the airway can again become obstructed. So to keep the airway patent, we introduce the airway devices. We have the oropharyngeal airway, nasopharyngeal airway, and the laryngeal mask airway, which we can easily insert. We don't need an advanced life support team to insert these things. So an oropharyngeal airway, This is actually an oropharyngeal airway, and the size of the oropharyngeal airway varies. The one which suits me may not be suiting another person. So you have to know which is the correct size of the airway. It is actually measured from the angle of the mandible to the angle of the mouth to the angle of the mandible. So this is the correct size of airway, and you have to measure the correct size of airway. And next airway is a nasopharyngeal airway. Nasopharyngeal airway, the size is measured from the nostrils to the tragus of the ear. And any patient who is conscious, who has an intact gag reflex, it is difficult to insert a oropharyngeal airway. It is better to go for a nasopharyngeal airway. Nasopharyngeal airway, you can see that it has a beveled edge at one side. You have to lubricate it sufficiently. Insert it perpendicular to the nose, not directly towards the head. It is perpendicular towards the nose, and the beveled edge should be facing the nasal septum. If you are facing it laterally, you can injure the turbinates and it can lead to bleeding. So introduce it in a twisting fashion. And regarding the oropharyngeal airway, you have to insert it upside down until you touches the hard palate. Once you reach the hard palate, rotate it 180 degree and then advance further. So this, first of all, you will be taking care of airway, then check the respiratory rate and the saturation of the patient. If the respiratory rate has not picked up, then there is something, a problem with the breathing of the patient. Then you have to support the breathing. For that, you go for an AMPU bag or a bag and mask ventilation. And whenever you are doing an AMPU bag, there is a technique known as easy clamp technique for holding the AMPU bag. E and C are the alphabets E and C. Actually, you can see that in the mask there is a triangular portion. This triangular portion should go towards the nasal end. And when you are holding the mask, the C is formed by your thumb and the index finger, which is placed over the mask, and your other three fingers are placed over the mandible of the patient. And make sure that you are giving a good seal, and then give ventilation. Now, how much to give? That is, in every 5 to 6 seconds, one breath. So 1, 2, 3, 4, and 5, you give a breath. Okay. And actually, in this case, actually, the patient is having high BP. Then after stabilizing the patient, you have to give parenteral antihypertensives to control the BP. And eclampsia, definitely, Maxel has to be given. 34 weeks pregnancy eclampsia. Finally, you have to terminate the patient.
Absolutely. So before we go on, just the size is so very important, because if you're using an oropharyngeal airway, the aim is so that she doesn't bite her tongue, she doesn't aspirate the blood, and her tongue should not fall back. So this tube should sit in the vallicula, that is the area between the base of the tongue and the hard palate. If your size is not right, it won't go till there, and the tongue will still fall back. So that's the importance of the size, which is very important. We have the next scenario, and we have 6 minutes left. A 28-year-old primary has come in at 35 weeks. She had something suggestive of UTI. The urine culture was asked for, and the consultant prescribed IV ceftriaxone and pantoprazole. The ceftriaxone test dose was given. Later, the full dose was also given, and both the drugs were given separately. But a minute or two after she got the drugs, she just struggled in the ward, and she collapsed. So you're thinking anaphylaxis. So Menon, what would you do?
Ma'am, this is a clear-cut case of anaphylaxis to the antibiotic given. So anaphylaxis, as we all know, it's a life-threatening emergency. We have to act quickly. That is the first point. And first, I would check for her vitals. I would look for hives. I would look for any edematous lesions over her body. And also, I would check her tongue to see for any swelling. And I would establish an airway if there is a laryngeal stridor. Then the first thing that I would do is to give a single shot of adrenaline. Earlier we used to get confused with the dilutions, but now there is clear-cut guidelines to give 0.5 ml IM, deep IM of adrenaline as immediately as you diagnose an anaphylaxis to any drug or to any food or anything. So the next thing I would do is to give, establish an IV line. and give her fluids and supportive oxygen therapy, and also antihistamines and steroids. Hydrocortisone can be given 100 milligram IV, and then if there is a stridor, and you can add on with bronchodilators like in nebulization with Butycort and salbutamol.
Yeah, absolutely. And I think here, very important, when we saw the first case where she had collapsed with an amniotic fluid embolism, it was a cardiorespiratory arrest. There, the adrenaline was given as 1 ml or 1 mg. Here, we give 0.5 ml IM, and you can repeat the dose in about 5 minutes. So important to realize that all these drugs, you can't run around for them, so you must have the crash cart. And the crash cart, ideally, you must have one in the ward as well, in your casualty and your labor room. And the organizational setup of the crash cart is also very important. See, as you see on top, you have the monitors. There is a space for the IV line. The defib is also there. And this is what sits on top. And there you can put up your own charts. There's a pediatric chart, because very often the person who's coming may not know the doses. But even for our obstetrics, use your charts that you need to know. So a green person who's coming to it for the first time will also know. Most importantly, it's so ideally divided as 4 drawers that you see for medications, venous access and devices, miscellaneous things. The miscellaneous will be even like an apron. You saw Pilisa had taken an apron from there. The airway devices and the airway access is also important. So important to have a checklist. Your nurse should be doing this with a date to see what all she has looked at. Is the defib working? Is the laryngoscope blade in condition? Is the battery kept out? Not within, so that it will leak, because the times you may use it are probably, maybe, hopefully very rarely, once a year or so. So are the batteries there? Are they not in the laryngoscope? And this all has to be signed off on probably a weekly basis, and this is done by the labor room staff. So this, I must say, I found this very, very useful to have a magnifying glass. I thought, because most of the ampules, and as age grows, even with the set of glasses, you can't read what is on the ampule. So I thought the magnifying glass was a very important part of that setup. I'm not going into the details, but all the medicines are there. This is the place where you have the cannulas, your tourniquet, your needles, the syringes, everything, and your IV fluids. Here is the miscellaneous set with the batteries, the apron, everything. And the last, you have your ET tubes and miscellaneous. So the key messages I thought my group can contribute. I think in a case of collapse, it's the question of the power of preparedness, because time may just mean a life. So you need to be prepared, not just in what you know, but also in what you have, how it has been organized, whether it is easily accessible, and power of training. We all need to be trained. We don't do this very often.